I'm delighted to be making this presentation.
Because
the Department of Clinical Pathology of Ekiti. I'll be presenting on clinical pathology of malaria, understanding the biochemical changes. I was humbly supervised by MS Onyerinde of DA. I'll be guided with the following outline. Malaria is a life-threatening mosquito-borne infectious disease that is caused by a Plasmodium parasite, and it is usually transmitted through the bite of infected female Anopheles mosquitoes. But there are other transmission routes for malaria. It can be transmitted through blood transfusion. It can also be transmitted through infected syringes, especially with those that deal with drugs when they share the needles and one of them is infected. There are basically 5 species of this Plasmodium parasite that infects humans with malaria. We have the Plasmodium falciparum, which causes the most severe cases of malaria. And then we have Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, and the most recent one that was previously infecting monkeys. Recently, people discovered that it is also infecting humans, which is the Plasmodium nolense. The symptoms of this disease include fever, chills, headache, muscle ache, fatigue, and dizziness. And this disease can actually progress if left untreated to complications like cerebral malaria, severe anemia, and organ failure. The life cycle of this disease is actually complex because it involves 2 hosts. The primary host, which is the mosquito, and the secondary host, which is the human. The disease affects majorly the tropical and subtropical regions in the world, and the World Health Organization has reported that 95 cases of this disease mostly come from the African region. The next slide. Over the years, malaria has affected many parts of the world, but as time goes on with progress in diagnosis and researches, some countries have been able to eliminate this disease. In the year 2000, 108 countries were recorded to be endemic countries. But as time progressed to 2023, 83 countries are now known to have this disease. We can see most countries affected are around this tropical and subtropical region because their weather supports the breeding of mosquitoes, and this helps in transmitting the disease. The next slide. This figure 2, shows the life cycle of Plasmodium. We can see the relationship between how it is transmitted from the mosquito, which is the female Anopheles mosquito. When it comes to take its blood meal, it inoculates this sporozoite, which is the infective stage of this Plasmodium, into the bloodstream of the susceptible host. This sporozoite migrates into the liver cell, as we can see in the diagram, and then they infect the liver cells and begin to replicate into schizoids. Thousands are formed inside, and then as they mature, they rupture, and the merozoites inside are distributed into the bloodstream. Although we have seen that there are some species that the merozoites or the sporozoites remain in the liver stage as dormant phase before, after maybe some months or years after the disease has been treated, they come up again, like the Plasmodium vivax and ovale shows that particular characteristics, which they are called hypnozoites. So they cause the relapse of malaria in some cases. So these merozoites, when they go into the bloodstream, we can see that they also infect the erythrocytes and then replicate further. There's more replication. Some of them grow into the trophozoites, which are the diagnostic stage when viewed under blood films. And some of them become gametocytes, which when the mosquito, another mosquito, comes to take a blood meal from this host, it picks up this gametocyte, which is the male and the female gametocyte, and then in the mosquito, as we can see, these gametocytes are fertilized, and then the zygote is formed, getting to the ookinete, and then to the oocyst, further replications, and then they replicate and release the sporozoites into the gut of this mosquito, and then the cycle continues as the case may be. This figure shows the pathogenesis of malaria infection, and mostly the manifestation of this disease is seen when these merozoites begin to invade the red cells. This is when the symptoms of malaria show face. So we see an infected RBC that is infected with these merozoites. It can cause, first of all, when it is infected, it will begin to stimulate the macrophages in the body, which will now lead to phagocytosis. And then this phagocytosis takes place, and then the infected red blood cells are being phagocytized, they are being broken down, the hemoglobin is also released and it is broken down, where we see the hemolysis leading to anemia, and then some of this, as it progresses, when it is not being treated, can result to renal failure, which we see as black water fever. And then this infected RBC, some of them begin to produce, especially the ones that are infected with Plasmodium falciparum, they release this histidine-rich protein at the surface of the RBC, making them to begin to break the hemoglobin into the heme form and further into the hemozoin form. Because the heme is toxic to the parasite, so it converts the heme into the hemozoin form, which will now make it suitable for the parasite. The infected RBC also can lead to some toxic mediators producing inflammatory products that the body now begins to stimulate inflammatory response, as we see as chills, fever, and sweat. And this can also lead to some metabolic disturbances, whereby there is now more stimulation of insulin, where the cells, the parasite is found, leading to hypoglycemia. And then the parasite also, the infected cells begin to form somewhat like sticky, they gum together around the vessels, the blood vessels, and that can lead to tissue hypoxia, where there's now blockage of blood flowing to certain tissues. More example like the liver, the lungs, and the heart. So that will lead to reduction of oxygen to those particular tissues. And those are some of the things that lead to the severity of malaria, leading to cerebral malaria, pulmonary edema in the lung, and then the disseminated intravascular coagulation. Because this will make the infected red blood cell to begin to coagulate in those vessels. The next slide. So this brings me to the crux of this study, the biochemical changes in malaria. As we have seen that malaria induces various biochemical changes in the host, including alteration in the liver, in the kidney. It even causes dyslipidemia, hypoglycemia, and leads to oxidative stress. These changes can contribute to the severity of the disease and complications like jaundice and renal failure. Malaria can cause acute liver injury, leading to increased activity of liver enzymes and bilirubin levels. These liver enzymes like the aspartate transaminase and alanine phosphatase with ALT, which is the alanine transaminase. Then it can also lead to renal abnormalities such as elevated urea and creatinine level, which are associated with heavy parasitemia in malaria cases, which contribute to renal failure. This happens when this disease is now being severe in that patient. Malaria can also lead to decrease in blood sugar, as we have seen in the previous slide, which increases glucose turnaround and alter the insulin sensitivity. Malaria causes decrease in essential electrolytes, although in some uncomplicated cases, the electrolyte may still be within the normal range. But as the case progresses, it can lead to reduction in this electrolyte level. But we've seen in certain cases whereby, even in further severity of this case, the potassium level begins to increase, which can lead to metabolic acidosis. The malaria can also alter the lipid levels, which we refer to as the dyslipidemia, whereby some of the lipids are increased, some are reduced. Then malaria also triggers immune response that produces reactive oxidant species and reactive nitrogen species, which can cause oxidative damage to the host cells. The parasite can influence protein synthesis, because during this process, especially when there is an infection in the body, there is rapid protein metabolism, catabolism. So this reduces the level of protein in the serum. The next slide. Plasmodium parasite, like I've explained before, digests hemoglobin into heme, which is releasing heme, and then the parasite further converts this heme into a crystalline pigment, which is the hemozoin. Because this heme is toxic to the parasite, so for it to survive in that erythrocyte, it converts the heme into the hemozoin. So this host immune response to malaria involves the production of cytokines such as the tumor necrosis factor alpha and other cytokines that can be released in the body during this disease. This slide shows the hemoglobin degradation and the formation of hemozyme, just like I've explained. When the parasite is inside the red blood cells, it breaks the hemoglobin, releasing the heme and the globin. The heme is further broken down into the hemozoin, and then the globin is broken down into amino acid. The next slide. This one shows when the parasite or the infected red blood cell is phagosynthesized in the spleen. You see that these cytokines are released that further attract antibodies and other cytokines in the body to help to quickly destroy this infected red blood cell in the spleen. The next slide. So we now look at the biomarkers. Since this, we have seen some of the things that have been altered in the body when someone is infected with malaria. These particular biomolecules can now be used as biomarkers, especially in the chemical pathology department, to monitor this disease. Because the World Health Organization actually has given the blood film, which is the microscopy method of diagnosing malaria, as the gold standard, especially to view the density of the parasite, to know the level of the parasitemia. But bringing it down to this department, we can obviously look at how this changes, how this parasite causes chemical changes in the body. And some of these biomarkers that I highlighted in this presentation is the first one, which is the histidine-rich protein that is produced majorly by Plasmodium falciparum. Like I said, it is always found at the surface of the red blood cell. And presently, it is used in the rapid diagnostic test in this case set where blood samples are collected and then the protein is reacting with the antibody from the cell. Then another biomarker is the Plasmodium lactate dehydrogenase. This is an enzyme that is produced by the parasite that plays an important role during the energy metabolism, because this parasite needs energy as it continues to replicate. So it uses the glucose to get its energy. Please, can you go back to that slide? So this lactate dehydrogenase converts during the anaerobic stage, the pyruvate that's supposed to be formed during the glycolytic cycle is now converted to lactic acid, and that's the reason why there is now metabolic acidosis during this malaria. The next slide. So hemozoin is also another biomarker that can be used, especially in this department, to diagnose or to monitor the severity of malaria. We have the C-reactive protein, which is a non-specific marker for inflammation. When there's any inflammation in the body, C-reactive protein will definitely be elevated. So in the case of malaria, it will also be elevated. Like we said, the cytokinins will be elevated in the case of malaria. Then the high urea, when you do the urea test and the creatinine, it will also be elevated, indicating that the liver has now been affected in this particular disease. The next slide. So liver enzymes, the AST and ALT and bilirubin levels are also indicative of liver damage. So when this test is carried out and then these liver enzymes are now elevated, it shows that now the liver is now being affected as this disease progresses. Then we have the electrolytes that can also be detected. As we said, they will be low, but in some cases, potassium becomes high, leading to that acidosis. Then another biomarker that is potential for diagnosing malaria is this haptoglobin, which is produced by the liver, especially when the hemoglobin has been released. So the liver produces this haptoglobin to bind to the hemoglobin to help remove the hemoglobin from the bloodstream. So with this, we can now use it to diagnose malaria. Although the haptoglobin, because it is now binding to the hemoglobin, it's going to be low in the case of malaria. So, but when it is high, we now look at it and say, okay, maybe it's other bacteria infection that is leading to that. Then the angiopoietin-1 and angiopoietin-2, these are proteins that are produced in the blood vessels, especially to help in remodeling the blood vessels, the vascular tissues. The angiopoietin-1 helps in the maturation of the blood vessels, while the angiopoietin-2 is acting countering to this one. So when the angiopoietin-1 is has been released, leading to the maturation of the blood vessels, this is also produced to stop the process, and then new cells are being produced. Then we have some studies, recent studies, that are using volatile organic compound, because we've noticed from the study that people that are infected with malaria, they release some certain compounds in their breath. Compounds like terpene and some other organic compounds. These compounds can be isolated or can be diagnosed in the laboratory from the breath using some absorbent material that will now be used, comparing them in a mass spectroscopy. The concentration of those compounds can now be related to individuals that are not infected with malaria. In conclusion, the biochemical alteration caused by Plasmodium infection are extensive and profound, extending far beyond the immediate impact on red blood cells. From the dramatic changes in glucose metabolism, as we've seen, and the oxidative stress to the dysregulation of lipid profiles and alteration in heme detoxification, the chemical pathology of malaria presents a complex and multifaceted picture. Understanding these biochemical changes is not merely an academic exercise. It is fundamental to developing new diagnostic tools, identifying new therapeutic targets, and improving patient management. So as we continue to unravel the intricate biochemical tapestry of malaria, we move closer to a future where effective prevention, accurate diagnosis, and targeted therapies can significantly reduce the global burden of this devastating disease. My recommendation is that we should integrate metabolomics, proteomics, and lipidomics data with transcriptomics and genomics to create a comprehensive system biology map of malaria pathogenesis. This will allow for the identification of novel biomarkers and pathways that are missed by a single omics approach. We should also translate promising biochemical markers into simple, low-cost, and robust point-of-care diagnostic tests for early detection, severity assessment, and differentiation from other febrile illnesses. And then we should also invest in training and then infrastructure to enhance biochemical analysis capabilities in endemic regions, enabling researchers and clinicians to conduct more sophisticated studies and apply findings locally. Together, I believe that this fight against malaria can be achieved, that we can gain victory over the disease, because so many countries that were previously endemic, today they are recorded as no malaria found countries. Thank you so much for your attention and for your understanding. Thank you.